Economic impact and long-term health complications of extremely premature infants with bronchopulmonary dysplasia. Bronchopulmonary dysplasia, also known as BPD, is a chronic lung disease most commonly found in premature infants. BPD affects 45% of infants born less than 29 weeks gestation with birth weight between 400 and 1,500 grams. Approximately 10 to 15,000 new cases are reported every year. BPD is associated with significant complications including prolonged need for mechanical ventilation, respiratory support, and oxygen use, longer duration of hospitalizations, and higher rates of non-respiratory comorbidities such as retinopathy of prematurity and brain injury. BPD patients often require frequent hospital readmissions and have higher rate of emergency room and doctor visits for recurrent respiratory exacerbations, infections, and reactive airway disease. Advances in neonatal care have resulted in improved survival rates of premature infants. Limited progress has been made to reduce BPD. It is essential to investigate what impact BPD diagnosis will have on patients' lives as they enter adulthood, and can we make any clinical assumptions about the impact of BPD as these patients begin to age. Next, we looked at the long-term health consequences with BPD. Noted researchers from the University of Oslo in Norway said, as modern treatment increases survival at increasingly lower levels of gestational age, the surviving children may have higher levels of morbidities for which they require care. In researching the long-term health issues associated with bronchopulmonary dysplasia or BPD, it was found that BPD predisposes individuals to the development of chronic respiratory disease in adulthood, including asthma and COPD. In 2010, a study out of Texas found that during the first 3 years of childhood, BPD showed significant abnormalities with airflow limitation as measured by lung function tests with no improvement. In 1999, research of individuals between 6 to 18 years of age, the average participant being 10 years old, found 92% had abnormal CT findings such as air trapping and abnormal functional residual capacity. The consensus among researchers is that all children diagnosed with BPD are potentially at risk for developing COPD later in life. In 1999, researchers in Finland reported that children with BPD suffered respiratory infections and needed antibiotic courses more frequently than their non-BPD counterparts. As these patients age, researchers are finding their lung function is not improving. In Australia, scientists found that those with BPD have poorer lung function in late adolescence than those without BPD, and may be deteriorating at a more rapid rate. The research into long-term health complications of BPD patients seems to point towards a later diagnosis of COPD. The picture is appearing to show continued lifelong care is necessary. A diagnosis of BPD can be a cause for concern for those unable to afford costs associated with healthcare. Research has shown that BPD places significant demand on health services and constitutes a significant health burden far beyond the neonatal period. As we have seen, cases with BPD report significant higher hospital admissions and as a result, higher costs of care. Infants with BPD require on average intensive hospital care for at least 120 days post-delivery. As of 2010, the presence of BPD in an infant increased direct hospital costs in the NICU by $60,000, not including physician fees. Among preterm infants, the single costliest complication during infancy is BPD, with an average cost per discharge of $116,000. Median medical costs for home care after discharge is $8,100 per patient. If the child requires hospitalization, the cost can increase up to $50,000. The overall costs of treating infants with BPD in the U.S. are estimated to be $2.4 billion per year, second only to the cost of treating asthma and far exceeding the cost for treating cystic fibrosis. One analysis found significantly elevated reports of hospitalizations with preterm births up to age 6, while a second report found increased medical needs between 6 and 12 years of age when compared to full-term counterparts. These studies indicate that negative consequences of preterm birth extend into later childhood. The cumulative costs of BPD greatly exceed the expected healthcare costs of a child unaffected. It is important that we as a society begin to account for and prepare for the healthcare needs of NICU babies as they age. In the treatment of BPD, current techniques have been ever evolving as therapies and medications have become available. In recent years, the goal has been to move away from invasive ventilation in favor of non-invasive modes such as nasal CPAP, bubble CPAP, NIPPV, and high-flow nasal cannula. Techniques such as the Ensure method are standard: intubate, surfactant, extubate to CPAP. And investigations into less invasive surfactant administration, LISA, are ongoing. With the development of the vibrating membrane nebulizer, the aerosolization of surfactant to the distal lungs seems promising. Several clinical trials and studies are currently testing next-generation synthetic surfactants, which are more resistant to inactivation and even anti-inflammatory. On the horizon of BPD treatment is stem cell therapy and its regenerative properties. Lung mesenchymal stromal cells and endothymal colony-forming cells regenerate lung tissue. In a case report reviewed during this study, bone marrow mononucleal cells were extracted and instilled via endotracheal injection. Then the remainder of the MNC cells were delivered intravenously. As a result, it reduced lung fibrosis and improved respiratory function of BPD, as well as the patient was discharged 17 days after pulmonary hypertension crisis and requiring high-frequency oscillatory ventilation. Another promising therapy is anti-inflammatory agents, including Kineret and Diabeta. Recent studies provided compelling animal data suggestive that these drugs prevent the formation of the NLR family and can indeed improve BPD.